Okay, so after hearing about the insight into lung cancer screening and then the various radiological patterns of lung cancer, let's see how to stage the lung tumors. So as all of you know that we use TNM staging for lung cancer, and TNM is an established uniform method of staging, and it depends primarily on the anatomic extent of the disease. It not only helps in treatment planning, it also provides us some prognostic insights, and it facilitates the uniform exchange of information across the various treatment centers and treating physicians. So currently we are into 8th edition of TNM, which was released in 2017 by International Association for the Study of Lung Cancer. And the main updations in this 8th edition over 7th edition were related to the tumor size and extent of involvement, which was in the T stage, and then subclassification of extrathoracic metastasis in M stage, while the N stage remained unchanged between 7th and 8th edition. So the terminology used in TNM staging is most often the cTNM, which is clinical TNM, or also called iTNM or imaging pre-treatment staging. And sometimes we also do use the word pTNM, which is pathological or surgical staging. And then yTNM when we stage the tumor after the completion of the therapy, or when we stage the tumors when there is recurrence. This is called rTNM. So CT scan and PET-CT, they remain the main imaging tools which are used for TNM staging. So let's start with the T descriptor first. So T descriptor, as they say, that every centimeter counts. It depends upon the tumor size and extent of involvement. And remember that in the 8th edition, there is separate criteria for solid, subsolid, and multiple tumor nodules or lesions when we give the T descriptor. So this is the chart showing the T descriptor in various categories. I think all of you must be aware of it, and I need not go into the detail of each of these subcategories. Just remember that the T staging is given based on the size, which is measured in centimeter, which is the largest dimension measured on lung window, and the extent of involvement of the adjacent structures by the tumor. So I will be discussing only about the contentious issues or where there are certain discrepancies, so that we can understand better. Whenever there are certain tumors when multiple T descriptors are applicable, in such cases, we need to see that we have to, the highest T category has to be chosen to give the T descriptor. For instance, this is one example. There is a FDG-avid tumor sitting here with associated collapse. So if you go by the size criteria, the largest dimension of this lung lesion is approximately 1.5 centimeter, which will make it as T1B, because the size is between 1 and 2 centimeter. But however, if you look at the associated atelectasis, that will make it as T2. So as I've told you that when there are multiple T descriptors applicable in any one patient, we have to choose the highest T descriptor. So in this patient, we will use the T2 stage for TNM purpose. Also on surgical and pathological review, it has been found that CT scan often overestimates the tumor size, and there can be inter and intra-observer variations while measuring and reporting the size of lung nodule on CT scan. And many other technical and patient-related parameters are also need to be considered, such as slice thickness, the reconstruction kernel, patient's level of inspiration at the time of scan acquisition. So these also contribute in the variation of the reported tumor size on CT scan. In addition, certain lesions can show central necrosis or cavitation. They can have ill-defined margins. They can be associated post-obstructive pneumonitis or radiation changes in the surrounding lung, which can pose a major challenge even to the most experienced radiologists while accurately measuring the tumor size on CT scan. So for instance, this is one example. Here you can see there is a tumor sitting here in the right lung, which shows a lot of speculations and some atelectatic bands. In addition, you can also see this band-like atelectasis anteriorly. So many times it poses a great challenge, how to accurately measure the largest dimension. And these kind of lesions very often show inter and intra-observer variations. Then the next pitfall comes in the measurement of subsolid nodules. In part solid tumors, which can be either subsolid or pure ground glass, as Dr. Ashu had shown you in many examples in a previous lecture, the solid component many times is very difficult to measure, especially when there are multiple complicated or scattered solid areas rather than a single focus. And there exists no consensus as to how to make the measurements uniform to measure this size. And this is, for example, this is one case where you can see that there is a part solid tumor which has multiple lobulated solid nodules within it, and we do not know which nodule to measure. Should we measure the entire this thing, or we have to measure separately these tiny lobules of these solid lesions within this part solid nodule? Then moving on to N descriptor. N descriptor, there is no change from the 7th edition. And any lymph node which is more than 1 centimeter in short axis diameter on CT scan is considered abnormal. And primarily, it is the structural location of the involved lymph nodes based on which we give the N descriptor on CT scan. So this is the class. There's a table showing that N0 stage means there's no lymph node metastasis. N1 when there's ipsilateral, peripheral, intrapulmonary or hilar nodes. N2 when there is ipsilateral, mediastinal, subcranial nodes. And N3 when there is ipsilateral, contralateral, supraclavicular or scalene lymph nodes, or contralateral, mediastinal, hilar or peripheral lymph nodes. So there are a few limitations even when we are evaluating the lymph nodes and staging, giving N descriptor for the TNM staging. As I've told you that any lymph node which is more than 10 millimeter in short axis diameter is considered positive based on CT scan. However, it has been found that a significant number of nodes which are smaller than 10 millimeter can be malignant, and so are the nodes which are more than 10 millimeter reported to be benign. So to take care of this discrepancy, FDG PET comes to rescue to some extent, and it has been found that sensitivity and specificity is significantly increased when we use FDG PET to stage the lymph nodes. But even on FDG PET, there can be false positive nodes, especially in TB endemic regions like India. So the inflammatory nodes will also show increased FDG activity, and thereby leaving us with no option but to go for invasive mediastinal staging. Then another issue with the current TNM staging is subcranial lymph nodes. Should we label it as N1 or N2 disease? Because if we follow the Neruke Japanese map, it defines a subcranial lymph node as station 10, which makes it as N1, while the American Thoracic Society describes subcranial node as station 7, which is N2 stage. And if you see that in 8th TNM, the majority of the data based on which this TNM staging was proposed has been collected from Japan, which uses this Neruke Japanese map. According to this Neruke Japanese map, the lymph node involvement of subcranial space is labeled as N1, and while the American Thoracic Society labels it as N2. So to overcome this discrepancy, I think all of you must be aware of this lymph node station, which is a unified international lymph node map given by ISLC, so that there is no ambiguity when we classify the lymph nodes when we use this international lymph node map. In addition, there are a few more features which are not addressed in this 8th TNM staging, like if the lymph nodes have irregular margins, and especially when there is non-regional thoracic lymph node involvement, like lymph nodes in the axilla, subpectoral, internal mammary, or diaphragmatic regions. And some authors suggest that all these chains should be taken as M1 disease, while others say that it should be N3 disease, especially the axillary chains. So further clarification and consensus statement is still awaited on these kind of lymph nodes. So moving on to the M descriptor. M descriptor is basically for metastasis. M0 when there is no distal metastasis. M1 further divided into M1A, B, and C. M1A when there is intrathoracic metastasis or any pleural or pericardial effusion or contralateral lung nodules or pleural nodules. M1B when there is single extrathoracic metastasis in a single organ, and M1C is when there are multiple extrathoracic metastasis. And this is the stage groupings based on the 8th TNM after we give T, N, and M categories to a different, to a particular scan. So there still are many challenges ahead in this 8th TNM staging. Moving on to pleural invasion, there is no way and no absolute criteria by which we can identify the pleural invasion, and we cannot differentiate based on CT imaging whether visceral or parietal pleural invasion is there at clinical staging. And the only CT finding which is considered confirmatory for chest wall invasion is the destruction of the bone. Then the present database used in 8th TNM does not provide any information on immunohistochemistry and molecular genetics, such as EGFR mutation. Then we also need to consider the presence or absence of driver oncogenes and immune status, which is again missing in this 8th TNM. So the prognostic impact is limited based on the 8th TNM staging. Then another issue with 8th TNM is when we see incidental pulmonary nodules, we do not know whether these are metastases, whether these are synchronous or metachronous lung tumors, or these are benign lesions. So the diagnostic dilemma continues when we see these kind of incidental pulmonary nodules. So what is the way forward? Way forward is the 9th TNM. Let's see when it is expected and what are the expectations in the 9th TNM. So data is already being collected to inform the 9th edition. In fact, most of the institutes have already provided their data, and this 9th TNM is scheduled to be published in 2024. So many new data elements such as patient-based, environmental-based, and tumor-related factors like genetic biomarkers, protein alterations, and copy number alterations have been added to stage the tumors for the first time. And many international collaborations are done to build a large and detailed database to achieve such objectives. So to conclude that imaging plays a pivotal role in staging the lung tumors, and radiologists must be familiar with the 8th TNM system and its pitfalls so that we can establish a fairly accurate communication with the referring physicians, and further collection of prospective data and detailed attention to unanswered questions will guide the developments for future staging systems. Thank you so much. Any questions? Thank you.